Hello, everyone, and welcome to our webinar on advocacy. I thank you all for joining us on this Tuesday. Hopefully, you're not on the East Coast to get a dire snow warning, and I hope you're warm and safe. So I'd like to begin and to talk about policy, and I think that's something that's not usually on our radar screen and doesn't often feel quite interesting in light of having a child or someone you care about with Duchenne. So the webinar agenda is really going to talk about three sort of different parts of the puzzle, and one is getting results to end Duchenne, and that's sort of our beginnings and why we did what we did and what that the MD Care Act looks like and what it has done. And then Dave Zook is going to be coming in, and Dave Zook, as you know, is with FaegreBD. We've known Dave for many years, and he's going to be talking about the advocacy agenda that is current and what we're going to be doing in Washington. And then Ryan will be coming into the agenda and talking about the conference overview and the tactics that are involved in this advocacy agenda. So let me begin by saying we want to get results in Duchenne muscular dystrophy. So we have an integrated strategy of how all these parts really come together. There are a number of different federal agencies that are targeted within the advocacy agenda. And for research, the National Institutes of Health are targeted. As you know, the National Institutes of Health is comprised of many different institutes, and there are basically about 4 of them that are involved in Duchenne. That would be the National Institute of Neurology and Stroke, NINDS, National Institute of Arthritis and Musculoskeletal, which is NIAMS, the National Institute of Child Health and Development, NICHD, and the National Institute of Heart, Lung, and Blood, or NHLBI. So those are 4 institutes that have direct relevance into Duchenne muscular dystrophy. Also, the Department of Defense is targeted. For the last 4 years, they have had a part in the competitive program, and the amount of money they spend has ranged from $3 to $5 million on a competitive program in Duchenne. Prior to that, they also were providing money, and this was specifically targeted money into Duchenne research. On CARE, the Center for Disease Control. The Center for Disease Control is sometimes an unlikely area, but within the Center of Disease Control, there is an institute called the National Center of Birth Defects and Developmental Disabilities, and within that institute is where they have some rare disease programs, and specifically there is one for Duchenne muscular dystrophy, and then it has expanded across the muscular dystrophies. And for access, the Food and Drug Administration. I think all of you are very aware of the FDA and the talk of a regulatory strategy and certainly the interactions that have taken place for the last several years and up to just last week. So what about policy and why is it important? So policy and legislation pave the way for advocacy, and that means that there is no government agency that can act without a road. So they need policy and legislation laid down so that they have this road by which they can make change or make decisions or make things happen. And so it's really important for policy, even though it doesn't feel like it's very important. But all of these institutes that we're talking about are guided by law. So if I'm going to just sort of retrace our steps and tell you that I think you probably have heard the story, my sons were diagnosed in 1984. In 1984, there was no policy at all with regard to rare disease. There was a woman out of Danvers, Connecticut, by the name of Abby Myers, who had who had 2 children with a rare disease, and she was pioneering legislation that would impact and cross-focus on rare disease. It was called the Orphan Drug Act. Now, the Orphan Drug Act is 1983, and it seems a long time ago, but what it did was pave a road for rare disease. Before that, the NIH didn't care about rare disease. You might remember that they were in the war on cancer and the war on drugs and different wars, but certainly no war on rare disease. So that legislation of 1983 laid down a road and said to everyone, rare disease is important. And not only that, the rare disease is important, and it wanted to incentivize industry. And so within that really was the orphan legislation that included the incentive for companies to get involved in developing drugs for rare disease and gave them 7 years of market exclusivity once they had received the orphan designation. So this is why that companies ever took a look at rare disease. Now, The other part of that bill was the establishment of the Office of Rare Disease Research, ORD. This was led by Dr. Steve Groff, who leads it today, although he's retiring. And within that ORD, what that particular legislation said to the ORD is that you need to begin convening people with rare diseases and talk about what they know and what they need to know, how well to characterize the disease, and begin to lay the groundwork about particular rare diseases over time. That legislation didn't really fund the ORD very well, and so what they could do very early on was really create meetings for a particular rare disease and fund the meeting. At that time, there was a very long queue. They only had enough money for one meeting a year. So in 1990, we were in that queue, and it would take a very long time to get that first workshop in Duchenne muscular dystrophy. So in Duchenne muscular dystrophy, the first workshop was held in 2000. Prior to that time, as you know, PPMD was organized in 1994. We had been writing letters to Congress about creating or really encouraging Congress to pay attention to Duchenne muscular dystrophy, but I'll tell you it was disorganized noise. And the reason it was disorganized noise is because the letters, some of them said, I want you to spend, Congress, we need you to focus attention on Duchenne and spend $40 million on it. Congress, we need you to do treatments for Duchenne. Congress, we need you to focus on finding a cure. So the messages were inconsistent, and that's why Congress might refer to it as disorganized noise. In 2000, the first workshop was held, and at that time, we met Joel Wood. You might know Joel from the foundation called FED, Fund to Eradicate Duchenne, and Joel's son, James, had just been diagnosed with Duchenne. I met him the first time on the phone prior to the meeting, and then just outside the door of the workshop, and said to Joel, we have inconsistent messages going to Congress. We have seen no impact whatsoever. Can you help us understand the process so that we can get results? On that day, Joel and I and a couple other folks went into the offices of FaegreBD. At the time, it was called Baker and Daniels, and we sat down with them and said, we need you to help us get results. That really was our first and monumental meeting when we signed on to work with them to think about what is it that would get results. PPMD had had an experience creating a Center of Excellence in 1995 at the University of Pittsburgh because we felt a Center of Excellence would bring together a really cadre of scientists in different areas of research that could focus on the opportunity for developing treatments. That DMDRC, or Duchenne Muscular Dystrophy Research Center, was the first center of excellence of its kind. It was led by Eric Hoffman. We felt that was important, and so that day in Dave's office, we really thought about what would a piece of legislation include in the muscular dystrophies to really change the landscape. And that day and later days, we would write the MD Care Act, which was inclusive of three different things. One is centers of excellence. We felt that centers of excellence would have an impact. The second was to develop a research plan. Again, a map to where we wanted to go. And the third was to have the Center for Disease Control look at the barriers in care because we knew that care was variable across the country and certainly across the world. So the birth of the MD Care Act. In 2001, there was a Senate hearing on muscular dystrophy, and that day for me was probably next to the cloning of the gene, the most important day in the universe of muscular dystrophy, and specific Duchenne muscular dystrophy. Before that, there was little or no federal investment in Duchenne. There were no registries in Duchenne muscular dystrophy. There was no surveillance. There was no standard of care, no outcomes. We didn't have any private investment at that time. The clinicaltrials.gov showed really nothing except the CIDD group with trials in steroids. And so the landscape was barren, and there was no company involved. We really felt like we were looking at the top of the mountain from underground. The MD Care Act was introduced in Congress on February 14th of 2001. We can credit Senator Wicker, the late Senator Wellstone, Senator Susan Collins, and others who took the legislation door to door, both in the House and Senate, and even in spite of 9/11 tragedy, when we felt that not only had our world changed, but had our legislation that was so meaningful, we felt going to have such an effect on our children, we felt that that was put on the shelf. It turned out that those senators and congressmen took that bill off the shelf after 9/11 and got it signed into law in December of 2001. so far, that bill, that road that was created for the muscular dystrophies and for Duchenne muscular dystrophy now has a $500 million investment, of which about $200 million of that has gone into Duchenne muscular dystrophy. The NIH invests, the CDC invests, the DOD invests. We have care consideration, and this was, again, the standard of care at the time, a consensus by more than 70 experts to say these are the fundamental pieces of care. There are 6 Wellstone centers. The MD StarNet collects surveillance and tracking of the muscular dystrophies, and in particular Duchenne. There's data collection because we received a grant and created and developed with the CDC the first registry. I think most of you are familiar, Duchenne Connect, which, just as a side note in terms of the tadalafil study and other studies, has recruited more people through it than most other clinicaltrials.gov or other areas. So we can see the impact of what these things are doing based on the Muscular Dystrophy Care Act. And so there's a coordinating committee that has developed an action plan that is being updated as we speak. So all of that has resulted in this amazing pipeline of drugs that you see in development. And without exception, the Muscular Dystrophy Care Act will impact sooner or later either develop the good idea or funded the company or helps with the clinical trials in terms of outcomes, surveillance, natural history, and certainly regulatory strategies, and ultimately with Center for Medicaid Services with access. So the impact of the legislation is monumental and important for our sons and for the quality of our lives. You can see now when in 1984, when my boys were diagnosed, we really didn't know the disease at all. In 1986 and 87, we had a gene and a protein product, and we didn't have a disease that was well characterized. We knew that without dystrophin, things go wrong, but we didn't know what those things were at the time. We had some ideas, and now you can see in a very real sense, we have the disease well characterized. We understand what targets should be approached by, and different companies are approaching each of these targets, thankfully. On the cardiac side, as you know, we believe in early intervention. We want to do diagnostics in terms of cardiac MRI, echocardiogram. We want to look at devices like ICD to monitor abnormal rhythms. We want to also look at the LVADs as potentially destination therapy, and certainly to change the policy on heart transplant. So to that end, we have begun a collaboration with the National Institute of Heart, Lung, and Blood and are moving into the cardiac realm to be very aggressive, because currently the strategies to date really do not impact the heart, and we do think that improving the function of these boys and preserving it over the long haul is going to really necessitate an aggressive cardiac initiative. Our regulatory strategy. Along the way, when companies started coming into the space, we recognized that the FDA really had to learn about Duchenne. They are challenged by 7,000 rare diseases, and we wanted them to know Duchenne muscular dystrophy better than any other rare disease, and we took about educating them. So we really, again, started what's missing and how can we get results. We really thought about the FDA, how are they going to listen to patients? And it was at that time that PDUFA 5, which is, again, the roadmap for the regulatory agencies, and in particular, the FDASIA, which is one of the articles within that bill that says to the FDA, you have to listen to the patients. You have to take their opinion into your review process and apply it. And so this is, again, setting the stage so that patient voice could be present within the regulatory process. We feel there's a greater need for flexibility within the review process. We know patients either too young or too old for inclusion criteria of trials are waiting way too long to have access to promising medicines. We wanted the FDA to understand this unmet need, particularly in Duchenne muscular dystrophy. We wanted to make sure that trials are inclusive of patients across the spectrum of the disease. We wanted to give them the tools they need to expand the use of accelerated approval and other pathways to include an adaptive approval over time. So we wanted to also understand their risk-benefit preferences. In our interaction with the FDA said that they understood that patients were willing to take a risk for benefit, but they really didn't have any data to confirm their beliefs. And so we took it upon ourselves to provide accurate and hard data in a very rigorous way so that they would, in fact, have those facts and that data at their fingertips so that they could no longer say, we think. Now they can say, we know. So the regulatory strategy also has need for solutions. And so these, again, are policy opportunities within PDUFA and FDASIA. So the provision to enhance the accelerated approval pathway the breakthrough therapy provision, patient-focused drug development on benefit risk. These are all the results that have happened through the regulatory strategy. PPMD, Genetic Alliance, Every Life Foundations, and all of you were involved in trying to get this FDASIA underway and into law so that your voice could be held. And this is only about a community that can gather together and have a consistent voice that gets things like the MD Care Act passed and certainly a regulatory strategy and approach like FDASIA. So our regulatory strategy was evolved, and one of the things we wanted to do is look at, so how, with all of these policies through PDUFA 5 and FDASIA, how does Duchenne fit in? And we wanted to, again, present to the FDA the hard facts of here's the policy and here's how we see it fitting so that we have a discussion and certainly an integration of those views into their review process. You might remember from the Putting Patients First, if you've read that we talked about accelerated approval, we talked about including the patient voice, we also talked about adaptive approvals. That is conditional approval like they use in the U.S., although, as you know, the FDA is not in favor of it now, but that's not to say they will never be in favor of it, but really to try to employ the vehicles and opportunities that FDA has to make them more flexible in the review to get these medicines to the patients who need them faster. And this is also giving weight to the patients and their voice. So the regulatory strategy also in terms of the benefit risk is what can we as a community do better? How can we educate the community, how can we educate the FDA about this unmet need, and not just in a certain particular group of children, but all across the spectrum of the illness. We recognize that we have no time to wait. Little children who can't participate in trials wait so long that they might not ever be able to participate, and people who are non-ambulatory might wait until it's too late. So how do we get this? How do we get them to understand that we need to get these people into trials and have access to medicines? We, as you know, have a Tell Your Story tool. We did the white paper on benefit risk. We have the survey results, and we've given them to FDA, and we have presented them in many public settings. So this has been really embraced by the FDA, and we're considering in discussions with them about expanding the survey to adolescents and young adults because they're interested in understanding if that equation of benefit risk is different from the parents. The regulatory strategy, one of the highlights of our strategy was the policy meeting in December. I think you probably are well aware that the EMA produced draft guidance. There was a meeting in London to discuss the points of that draft guidance, and then we wanted to harmonize efforts both in Europe and the United States because these are the two most well-respected regulatory bodies in the world. And we agreed with them that we would hold a policy forum to discuss the points of the draft guidance from Europe to basically recreate the meeting that happened in London. And Dr. Woodcock said to us during that early meeting to prepare for a policy forum that she felt like this community was well prepared to write a draft guidance. Within the policy forum, you might, those of you who watched or were present, might remember that she said, we share your goal of getting disease-modifying therapies onto the market as rapidly as possible. And you might further remember that Dr. Ellis Unger said that Duchenne is their highest priority within the agency. That's because of the voice of patients really being raised, not only in Congress, but into the regulatory agency. So I think we can celebrate the fact that we are being heard, not fast enough, not enough, and we'll continue those efforts. So the draft guidance, just a little bit of an update on the draft guidance. December was the meeting. We have a summary which we are finalizing and we will publish. The steering committee has been identified. 6 individuals serve on the steering committee. The working groups, there will be 7 of them. They are established with chairs of steering groups, and they include benefit risk, biomarkers A and B. Biomarkers A is protein, dystrophin, and utrophin. Biomarkers B is serum biomarkers, MRI, and we differentiated those 2 working groups because those are 2 different conversations. There's also conversations on outcomes and on policy, and so the working groups are being established. The chairs have been invited, and we will invite the rest of the people who have shared interest to serve on one or another of those working groups. We will have a meeting during the upcoming Advocacy Conference on Monday from about 8 to 1 to bring further update and clarify and discuss some of the concerns that we might have going forward. There will be a community advisory panel, and anyone who wishes to serve on the community advisory panel, please contact Ryan or I, and we will certainly be happy and thrilled to have you participate on the panel. The purpose of the panel will be to review all documents that are produced by the working groups and reviewed by the working groups, and then ultimately to give comments to the steering committee so that in May we have a final draft guidance to submit to the FDA for consideration and review. Looking ahead, we want FDA to use all of the regulatory tools for Duchenne therapies. We want them to eliminate placebo. We feel that we have sufficient natural history, and we are at a time when that is sufficiently rigorous that we should be avoiding placebo. We are also talking to the Center for Medicaid Services. Again, this is policy. We really need to make sure that the reimbursement is there for these therapies that are going to come online and that those therapies are accessible by people who have Duchenne all across the spectrum, to include the girls who are diagnosed with Duchenne. Often I know that they feel quite left out of the inclusion criteria for trials, and I worry, and I know they're worried about being left out of the access to medicines. We want compassionate use. It's really hard to watch a trial get up online and running and really have a narrow subset of the individuals involved while those too young or too old are waiting for some news about whether or not this will be approved some year down the road. We think that companies need to sign on as our partners and really think about compassionate use for others across the spectrum of the illness who might not be included in the inclusion criteria, and they should have access to these medicines once safety's been established and while they're in process of getting approved. We want also to talk about the policies with regard to employment and independence. As you know, some of our young men are employed, and depending on their income threshold, they may well lose their services should they make too much money. That has to change. Our policies have to promote employment for these young adults as well as their independence. This is where policy lays down the road and paves the way, and we intend to continue to do that with your help. So from that, I'm going to turn over to Dave Zook. As you know, Dave Zook is a principal of FaegreBD. He's also an attorney, and we've worked with him since 2001. Dave?
Thank you very much, Pat, and good afternoon, everyone. I'm pleased to be with you today to talk a little bit about the advocacy agenda. What we'll do is spend a little bit of time on the 2013 results, really what your advocacy has helped produce, and then talk about the development and the priorities that we've set together for 2014 as we approach the Advocacy Conference. So, starting with the 2013 results, as Pat noted, the MD Care Act really is the primary pathway or framework for the development of the research, care, and access priorities for Duchenne. And so, periodically, the legislation needs to be updated. Like any road, it needs to head in a new direction. It needs to reflect the advancement of science, other new knowledge. And so every several years, PPMD takes a look at how this act can be updated, and did so about 2 years ago, identified key areas of improvement at those agencies that had identified, as well as new partnerships that might be developed going forward. The result was the MD Care Act amendments. The second time, in fact, that the bill has been amended since it was originally introduced. And so our objective last year was to refine, complete, and introduce that legislation and begin to develop congressional support in the first session of this Congress. And that got off to a pretty good start. Several of you, I think, were involved in that effort. We did get the bill introduced in a bipartisan way, very important in this climate, in both the House and the Senate. It enjoys now 78 co-sponsors in the House, folks that are lending their support to the bill as it gathers momentum, 17 in the Senate. And we'll talk about the focus that we have for this year to improve that and to move the bill forward. In the research area, as you know, we've been hard at making sure that the agency, the National Institutes for Health, has sufficient funding, and just as importantly is implementing that MD Care Act in key areas of scientific investigation and partnerships that can help produce a change in the trajectory of the disease. So Last year, we worked very hard to protect the NIH funding for Duchenne and more broadly. That was in the face, of course, of several efforts to reduce the federal budget. And it came out in pretty good shape. So it's about even with last year, and we're hopeful that it will continue to be able to grow now that Congress has clearly set it as a priority, even in this environment of budget cuts. And then in terms of identifying and driving those research priorities, biomarkers, as Pat mentioned earlier, have become increasingly important for enabling the development of therapies and for advancing them in the regulatory process. So Congress, at our request, directed the NIH to work with the FDA to fund additional research in this area, and even now we're working to implement that direction with the agency. Further, the NIH, as we began this advocacy both at the MD CARE Act and for the annual funding levels, committed to a more frequent effort to meet through the MD Coordinating Committee and set the agenda. That, as you may know, some of you, has not been as regular as we need it to be, so that the plan can be updated more regularly, and they've committed to do that, and we'll have to try to hold them to that. And as Pat also noted, the Defense Department research funding was continued for the fourth year, another focus of our advocacy in collaboration with others. In terms of care, I think it was another area of progress and results. The muscular dystrophy program at the CDC was restored from the sequester cuts, $5.6 million in the current year to continue the programs of surveillance, public health, development of the care considerations. That expansion of the most important, probably, development in the last several years to affect the quality of care will now move forward and expand to include adult populations. The access area similarly was an important area of progress this past year and through your efforts as advocates. Pat already mentioned the development and the delivery of a unique benefit-risk study to FDA to help them in that effort to understand Duchenne and muscular dystrophy more completely as they handle the various applications coming from the pharmaceutical industry. The first ever regulatory policy forum, again, continuing that spirit of patient involvement. And this was really seen, I think, by the rare disease community as a whole as a very important development under the new FDASIA law, that this kind of engagement was taking place and taking place in a very purposeful way, pointing towards the development of the regulatory guidance that Pat earlier described. So, looking into the current year, when you come to Washington later this month, I can't guarantee it won't be snowy, but I can guarantee you that we will be prepared to have a very high impact agenda. And there are a couple of things that I'd want to mention that those of you who are veterans know, but want to really make clear to folks that there are a couple important points in the strategy here. One is that you really don't make much progress if all you do is complain and don't bring solutions forward. Again, the 2014 agenda is designed to build upon the MD CARE Act to have specific ways in which Congress and the agencies can continue this progress. And the other is that it's a very competitive situation. There are many groups, many issues, many disease areas that are trying to make progress. So within a limited budget, it is a competition. And I hate to put it that way, but the fact is that we are competing for attention. And so our efforts to be focused and to be engaged continuously, what you're doing as advocates to work with members of Congress needs to be continuous to be effective. And that's something that I think PPMD and the advocates have done very well. So as I noted, in terms of driving results for the coming year, the MD CARE Act amendments is our highest priority. We need to build that co-sponsorship and move towards congressional committee action. Several of us met earlier this month with the key committee staff that are charged with that responsibility to make sure that we understood what they need to see from us, the support they need to see on the committee, the concerns that they may have, and how we can address that. Make sure that when you're here in Washington, we're having as much impact as possible. On the research front, in addition to what we're doing in the MD CARE Act amendments, we'll need to continue our efforts to make sure that the research funding levels are sustained. We know that the Wellstone Centers are just critical to that pipeline that was earlier displayed and need to continue to be productive, really at the center of the research agenda. So our efforts around NIH funding will continue to focus there. We'll look to provide the resources for that combined biomarkers initiative between NIH and the FDA to support drug development. And finally, in the research area, we believe that the progress and the impact of the DoD program to date means that it needs to be continued. So we'll focus in 2014 on keeping the funding available for the Defense Department. In the care area, we know that the MD StarNet has been very productive for understanding the disease. We need to make sure that the information coming from that work is shared more widely. Part of that will be focusing on getting the MD StarNet infrastructure working together among the centers and also with the NIH. That will be a focus for this year. We'll want to ensure that the funding, of course, remains in place also so that we can continue the care considerations expansion both to adults and then turning the CDC increasingly to quality of life for underserved populations, an area of important focus for us in 2014 with the CDC. And then finally, as Pat noted earlier, the conference itself will be a very important time to continue to build the regulatory guidance, to bring the patient voice in a focused way to that discussion, and then in our advocacy on Capitol Hill, to make sure that the Congress is supporting the use of all of those regulatory tools that Pat earlier described to enable the advancement of the Duchenne-related therapies. That will be a focus of our agenda as well. So what does the landscape look like? Those of you who've been with us in the past will recognize this slide. It is really the core to our advocacy strategy, bringing your voices forward, making you available to members of Congress in a very powerful way, and then guiding that discussion with a very focused agenda that sets a priority for the federal government, continues to refine that priority, and most importantly, in this very difficult budget and policy environment, is demonstrating what we call the return on investment. That means the taxpayer resources that have been going to this area now since the enactment of the MD CARE Act and the programs we've described are making a difference. And fortunately, we can demonstrate that very clearly, both in terms of the research pipeline and in terms of the impact on the quality of life, themes that we've been talking now to Congress about for a couple of years and have been very important to sustaining their support. As we'll talk about in greater detail when you're here in Washington in a couple of weeks, the environment continues to be challenging and really calls for us to be focused. And we have, as you know from daily reports in the paper, divided government that makes consensus much more challenging. I would note that more recently that has gotten a little bit better. I think they've begun to understand that people across America want progress on key issues, and hopefully that'll be helpful to us as we look to advance the MD CARE Act this year. The budget issues that I mentioned persist, but we have a budget deal put into place in early this year that will allow the appropriations in 2015 to move forward on a more, we hope, more clear pathway. And if that can happen, then the prospects for protecting and advancing the funding and the priorities in the agencies that I described earlier will be improved. So while a challenging environment, some things are beginning to improve that help our agenda and help our advocacy. And importantly, at the end of the day, it is the advocacy by each of you that makes the difference, that keeps our priorities, the MD CARE Act, the research, care, and access in Duchenne at the top of congressional and federal priorities. Next, Ryan Fischer is going to address the 2014 advocacy tactics. Ryan?
Thanks, Dave. Just to look at what I'm going to cover, I'm going to look at the status of the bill, talk about our targets in the House and Senate, discuss what the fly-in will look like and what the ask is going to be, and the at-home advocacy strategy for those of you who are unable to make it to the Hill, and finish with some social media tools. If we look at the current status of the bill, as mentioned before, the bill was introduced a year ago, and we have managed to garner 78 co-sponsors in the House and 17 in the Senate. We need to up these numbers, and we're currently awaiting action by the relevant committees in the House and Senate. If you want to see if your member has co-sponsored the bill yet, you can go to our website /co-sponsors, and there's instructions on how you can reach out to your members and whether or not they co-sponsored. Regarding the relevant committees, let's take a look at the Senate Health Committee. This is the Health, Education, Labor, and Pensions Committee. This is the Committee of Jurisdiction in the Senate side for our bill, and as you'll notice in red, you'll see the co-sponsors we've been able to already secure. We need to up these numbers. We have a better chance of moving the bill if we up these numbers in both the Senate and the House on the relevant committees. We've been targeting these states for folks to come in for the conference, but we will also be targeting them for action alerts for at-home advocacy in the coming weeks. Same thing goes on the House side. You'll see the Energy and Commerce Committee, and you'll notice we've got several of these members on as co-sponsors already. Again, same strategy. We need to up these numbers. If your member is not on either committee, it doesn't matter. We still need their co-sponsorship. This is just part of our strategy, is getting as many on the relevant committees in order to advance the bill. So for the fly-in, I just wanted to just show a brief agenda of what the days are going to look like. We have 135 advocates registered, 25 states, 66 districts, and people are still registering as we speak. Sunday will be the usual advocacy training from 3 to 7. We will feed you. On Monday, we're going to do an update on the policy guidance in the morning, and then there'll be Hill meetings in the afternoon. That will most likely be on the Senate side on Monday afternoon. Tuesday, we have the Hill meetings in the morning, and then we will have a congressional briefing about the impact of the MD CARE Act, and that will be in partnership with the MDA and the Foundation to Eradicate Duchenne, FED, and then finish with Hill meetings at the end of the day, Tuesday. So what are we asking Congress to do this year? I know this has been mentioned several times, but obviously the highest priority is co-sponsor the MD CARE Act. Our other ask will be about supporting our appropriations request and a request to submit report language. There'll be a member letter being circulated on both the Senate side and the House side, and we will be giving more details about that in the next 2 weeks. So, advocates who take the Hill, members who have not signed on as of yet will be asked, obviously, to co-sponsor the bill. For those members who have signed on, we are going to ask our advocates to focus on thanking the member and asking them to sign our appropriations letter. So, same message from the at-home advocates. We're going to be sending out a number of tools for you to use that will include action alert emails and a short phone call script, because while we're on the Hill attending meetings, we really want the at-home advocates to make phone calls and to really, really flood the offices with the message to co-sponsor the MD CARE Act. And then there'll be a plan for follow-on district meetings, in the very near future. So some social media tools, as usual, we'll be using Facebook, to share action alerts, and I do recommend everyone to, if your member has a Facebook page, to like it. Twitter, same deal. Follow your members, and we're going to be sending out tweets. There'll be on the Hill advocates tweeting while we're on the Hill with the hashtag MDCareAct. And finally, we're asking everyone to sign up, if you haven't done so already, for our action alerts so you receive all those communications while the Advocacy Conference is underway. We just want to acknowledge the fact that Duchenne has been a focus on the Hill and will be throughout this month. It's being talked about by members of Congress. It's a wonderful thing. There was a well-attended congressional briefing on eteplirsen and accelerated approval on February 7th. And we have our congressional briefing on the impact of the MD Care Act that will be happening on the 25th. And something to note that it's Rare Disease Week on the last week of February. So, we really have some solid asks for Congress. And I think that Duchenne is being heard across the Hill, across the country, and I think we should be proud as a community of what we've accomplished to date. So with that said, we want to take the opportunity to take questions from anyone that has them. And if you have follow-up questions, you're obviously able to call or email Dave or I afterwards. So there was a question regarding, and Dave, if you could field this, exactly what an appropriations letter is and what that means, if you could clarify that.
Be happy to, Ryan. Thank you. So an appropriations letter is a communication from members of the House or Senate to their respective House or Senate appropriations committees in support of funding in a particular year. The way this works is we try to get a Republican and a Democrat in both the House and the Senate to lead those letters, and then they have their colleagues sign on. We try to get as many of those signed on as we can to demonstrate strong support for the funding request. That'll have a number of our issues on the appropriations letter. One of the things that we'll talk about in detail at the training is that there's some members who, because they're members of the Appropriations Committee, don't sign those, and you'll know if you have members of Congress that serve on the committee and have to approach it a little bit differently. But that's essentially what an appropriations sign-on letter is.
Great. Thank you, Dave. There was a question that came in about how do you find out if your member of Congress has signed on to support the MD Care Act amendments. If you go to our website, parentprojectmd.org/co-sponsors, you'll be able to check and search to see if your member has co-sponsored. If you want me to look that up, you can also email me and I'll respond. Rabbit.
All right. First of all, thank you. If there are any other questions, please feel free to send them over to us, and we'll be happy to answer them. We're looking forward to our Advocacy Conference. This is our 13th Advocacy Conference this year, and later our 20th conference in June in Chicago. So I really wanted to thank the whole Duchenne community, and because this is the power of advocacy. The MD Care Act is thanks to all of you who've contacted the people who represent you and encouraged them to support this bill. So I think you can be satisfied and thankful that we have a full pipeline. It is never full enough, so we need to continue funding to encourage companies, to encourage good ideas, to encourage the CDC to improve care, look at gaps in care, be able to treat our very young and our young adults and young men with Duchenne. So I think this is really such an important piece of legislation that we couldn't have been where we couldn't have gotten where we are today if it wasn't for setting this in place in 2001. So I wanted to thank you all for joining us. I hope to see you in Washington or alternatively in Chicago in June. And I really thank you for all you do for all of us. Thanks so much.